What are the latest clinical guidelines for treating episodic migraine? Have you ever wondered what the most recent recommendations are for treating episodic migraine? Well, you are in the right place. Let's break down the latest clinical guidelines that can help manage this condition effectively. Episodic migraine is defined as having 1 to 14 headache days each month. The American College of Physicians issued new guidelines in early 2025, focusing on the prevention of episodic migraine in non-pregnant adults treated in outpatient settings. These guidelines suggest starting treatment with a single preventive medication, also known as monotherapy. This approach allows for adjustments based on how well the patient tolerates the medication and their response to it. First-line preventive medications include beta blockers such as metoprolol and propranolol. Another option is the antiseizure medication valproate. Additionally, a serotonin-norepinephrine reuptake inhibitor, known as venlafaxine, and the tricyclic antidepressant amitriptyline are also recommended. If patients do not respond well to these first-line options, the guidelines suggest trying migraine-specific therapies next. These include calcitonin gene-related peptide receptor antagonists, often referred to as gepants, like atogepant or rimegepant. There are also calcitonin gene-related peptide monoclonal antibodies, such as eptinezumab, irenumab, fremanezumab, or galcanezumab. If these options are not effective or tolerated, the antiseizure medication topiramate is suggested as another monotherapy option. The recommendations are based on systematic reviews of clinical evidence, patient preferences, and economic considerations. However, it is important to note that the strength of evidence is considered low certainty. No single medication stands out as the best choice in terms of effectiveness. Cost and patient values play a significant role in deciding the treatment plan. From the perspective of headaches and migraines, these guidelines stress the importance of starting with well-established preventive medications that have shown to reduce the frequency and severity of migraines. The inclusion of newer migraine-specific agents like calcitonin gene-related peptide antagonists reflects advancements in targeted therapies, which often have favorable safety profiles and are effective for many patients. In practical terms, these guidelines recommend starting preventive treatment early for patients with frequent episodic migraines. This can help reduce the number of attacks and improve overall quality of life. It is also important to choose the initial therapy based on individual patient factors, such as other health conditions, how well they tolerate medications, and cost considerations. For those who do not respond to traditional preventive agents, considering migraine-specific calcitonin gene-related peptide-targeted therapies is a good option. Regular monitoring of treatment response and side effects is essential to adjust therapy as needed. Overall, the latest clinical guidelines provide a structured approach to preventing episodic migraine with various pharmacologic options. This approach aims to reduce the burden of migraines and improve daily functioning for individuals affected by episodic migraine.